or not?
Yeah, fine.
That's okay. Thank you. Carry on.
Yeah, a warm good afternoon from southern part of India. It's such a nice experience to be with a very different group of specialists here. This is first of its kind, which usually we restrict ourselves to our specialty. The idea behind doing this particular topic amidst this forum is because dentistry and the oral cavity are very, very closely linked to otolaryngology and the ENT specialists as well. So I'm sure many of you can take some cues from this particular presentation today. So before going into the topic, I would like to quickly touch upon what does atypia and what does dysplasia mean. So in a broader sense, why are we so much bothered about these two particular topics? Because as a pathologist myself, we have been facing regular challenges in differentiating these two areas because of a very important challenge which oral cavity throws on to the mankind than any other part of the body. So that is what actually makes this particular differentiation very, very different. And again, while saying this, just in a single line, the difference between atypia and dysplasia is that atypia is more related to a cellular change and dysplasia comes along with the cellular change, along with the architectural changes. So that is what you can see in this particular picture. And this has always been challenging, especially in decision making in potentially malignant disorders. And you all know that India has a lot of habits, deleterious habits in terms of chewing of tobacco. And chewing of tobacco was considered in earlier days as a very important nutritional habit, but later it turned to be a very dangerous habit because of the additives which actually went on to those particular substances. So that is when it became a trouble. And we as oral cavity people who takes care of the oral cavity, we constantly face challenges in such situations. So you know how prevalent oral cancers are, and it is the sixth most common cancer. And especially in India, the sixth most common cancer prevalence rate is in global level. But in India, it is actually the third most common cancer. And that is because of the usage of these habits, habitual practices, and so on. So having said that, there is a gradation between the normal mucosa, between the potentially malignant disorders, and then comes the other end of the spectrum, that is cancer. But having said that, are we able to clearly demarcate that this is normal and this is potentially malignant disorder, that is the intermediate phase, and the next comes the cancer? Is that delineation happening? So that is what is very important, and it is not always the same, and the differentiation or demarcation or just putting a definite boundary between these three areas are a very big challenge as far as the oral cavity is concerned. I'm sure my peers at the ENT specialty would appreciate this particular picture. This is a very big challenge because right from this particular junction where the gingiva meets the hard tissue, from this particular junction, just to mention about this particular area, you have two interfaces. One is non-keratinized and the other is keratinized. I'm just talking about this simple area in where the soft tissue comes in interface with the teeth. And that is the area where there is constant threat by the microbes and so on. So the challenge is very, very huge, and you have a specialized mucosa here. The sublingual region presents with a very different permeability, and the buccal mucosa has a different structure. The retromolar area presents with a different structure, and going to the posterior area, you all know better than what we actually know. So that is how it is. So because of this complex architecture, the grading, the histopathological grading, and obviously the disease process itself is highly challenging. And that is what actually makes the grading itself very, very difficult. And the drawing boundaries has not been possible with oral epithelial dysplasias. And it is always very challenging. And that is why the prevalence rates are very, very high. So the anatomy is definitely an enigma, and we've been facing this every day, every single day. There are cases which keeps coming up, and I'm from an institution which handles a huge number of patients, and we regularly have cases which we have to differentiate and we have to report, and it's always been a challenge. And despite of having a very big group of pathologists here, we always have daily discussions where definitely there will be inter and intra observer variability. So that is a problem. Sorry, inter and inter observer variability is very, very huge. So what exactly happens is, as already said, the line, demarcating line is not there. So how are we going to handle this? Only one particular statement which every literature talks about as far as oral epithelial dysplasia is concerned is that it regularly says that atypia is cellular, whereas dysplasia comes along with architectural changes. So those aspects have to be still be more validated, and it has to be quantified in the sense multiple multi-centric studies has to happen, and then we have to assess it on a very, very large basis, and then design a proper study, and then only then we'll be able to at least do some justification in this particular area. And another big challenge is, as already shown, about how complex the anatomy is. The other challenge, biggest challenge is there is constant physical, chemical, and microbial abuse in that particular area. And you might think that other body cavities also have such a challenge, but it is more in oral cavity, because you know that the thermal changes are very, very high than other parts of the body. So all that actually makes it or worsens the situation. So what is the currently available systems talking about, and why are we so concerned? This is a summary of the currently available system. So if you can quickly look into it, the last three criteria, so right from very old criteria of the intraepithelial neoplasm, that's intraepithelial neoplasia, where there is the stage 3 or the severe type of dysplasia, where we have carcinoma in situ. That word is discontinued now. It is, so we have almost more than 2/3 of the cells being showing an alteration. So you can see that WHO has been trying to do its best from a very long time. It's been there for almost now 3.5 decades of lot of revisions, deliberations, but still till date, even the systems which are proposed by WHO are of lesser specificity, and the reliability is still a big challenge. And this being the apex body of healthcare, if WHO is not able to put such a system, so what is exactly the problem? So there are still a lot of things which are happening, and the main thing which I would actually try to put upon in this particular forum is that there are some criteria which are comparatively better, which will actually delineate that particular gray zone, the gray zone which is intermediate between the mild and the severe area. So that has to be clearly delineated, and having a very close watch on other systems, particularly the urothelial carcinomas and the thyroid as well. The system of histopathology reporting, especially in this intermediate lesions, are better. But knowing that it is better in other systems, why are we not able to make that happen in oral cavity is because of these challenges, where there are huge type of physical and microbial challenges, and that actually changes the environment very quickly. And there is always a spectra which is merging with each other without clear demarcation. And that is what actually makes the grading very, very challenging. So definitely from now, if there is a grading system which is going to be proposed by the WHO, they have to definitely take cues or add on a molecular marker, which will definitely cause that or identify that demarcation, or which will be able to clearly cut or clearly identify the differences. So without which the creating a definitive adjunct parameter, doing a differentiation or doing a grading with just the routine hematoxylin and eosin may not be possible, because we have been having the same confusions for over so many decades, and it shouldn't be like that, considering the enormous amount of advances which has happened. So these markers have been reported to have very clear demarcating ability. So it is up to the apex body to give us a very clear adjunct parameter to differentiate that, and these parameters should be considered to in the current classification systems or the upcoming classification systems. Only then there will be some meaning to this, or to make this particular area, to make the gray area more clear and more white. So that is more important, so that we are able to render more preventive actions. And the most important thing is to identify them at the right time. So the creating the intermediate category has to be very, very clear, and the patient should know that they are under the risk category. And we should be able to clearly state that this is the status, and this is the kind of follow-up which is needed, and this is the kind of treatment which is needed. And all that are very, very blurred now. So that blur feeling shouldn't be there, and it should have a very, very clear pattern. And that is very important. And that is what we are as healthcare providers should be responsible about. And it has to be taken to the apex body, and it all starts with this. And thank you so much for this excellent opportunity. And it really gives a lot of learning, because I've been hearing all my experts talk in the neighboring area. ENT, we are very closely associated with. It was wonderful listening to all of you. And these are my acknowledgements. And thank you so much for such a wonderful opportunity. I'm here to take questions. Thank you.
Thank you, Dr. Ramya. Excellent presentation.